Well, good evening and welcome to tonight's live webinar. I'm Dr. Steve Parker and I'm delighted to be your host for what promises to be a fascinating and important discussion. We're going to be talking about a topic that doesn't always get the attention it deserves: persistent post-procedural pain, a condition that can significantly impact our patients and challenge even the most experienced clinicians. Now, with me tonight are two of our wonderful DN experts. First, we're privileged to have Dr. Amanda Nguyen, oral medicine specialist, who will be leading tonight's presentation and sharing her insights into chronic orofacial pain conditions. We're also joined by Associate Professor Geraldine Moses, clinical pharmacist, who will bring her perspective on medication-related considerations and strategies. Now, together, they'll be unpacking real-world case studies, highlighting risk factors, discussing management strategies, and giving us practical communication tips for navigating these tough conversations with patients. Now, as always, this is your chance to engage directly, so please feel free to send through your questions during the session, and we'll aim to answer as many as we can. So let's get started. Over to you, Amanda.
Thank you very much. So we will get started. So what I'm going to talk about for my portion of the presentation is what and how common post-surgical pain is, why it's an issue, who is at risk, if we can actually predict and stop the transition, and then, as Stephen said, things that things that clinicians do not want to miss, and I'll share some practical clinical tips. So one of the areas of emerging interest at the moment is the transition from acute pain into chronic pain. And there can be two people that have the exact same injury, and one person may heal fine after that happens, and then the other person may actually then develop chronic pain. And it's actually of much interest for us to actually know if there are risk factors that will make it more likely for someone to do so. So before we get into that, let's talk about some areas of pain and some different of the aspects of pain, and then I'll introduce the concept of neuropathic pain. So is all pain the same? No. And there are two or three major types of pain, the concepts of which I'm going to introduce now. The pain that we all know is our normal protective pain, which is also known as nociceptive pain. So I put a little fire there. This is the type of pain that if you touch something hot, for example, it lets you know to pull your hand away. Now, when the source of the injury is gone, the injury itself usually heals with no problem. So this is the normal protective pain that we are all familiar with. Now, there are instances where this type of pain can actually go wrong, and we call that neuropathic pain. Now, the definition of neuropathic pain is where there is lesion or dysfunction of the nervous system. So the cause of the injury has gone away, normal healing time has passed, but for some reason, the pain persists. Now, the third type of pain that I'll just introduce really briefly, although we're not really talking about it during this presentation, is a type of pain that's called nociplastic pain. So the definition of neuropathic pain is where there is a lesion or dysfunction of the nervous system. Now, patients can have pain even though there is no demonstrable issue with the nervous system. And in the past, this would be an issue because these patients, were the ones that were thought to have, pain in their brain, or like pain that had sort of nothing that could prove that they were in pain. The reason why a few years ago the definitions of pain changed and nociplastic pain was introduced as a concept was to give these patients a proper diagnosis so they wouldn't feel that their pain wasn't real. So neuropathic pain is the focus of our presentation today. So is where something has gone wrong with healing, something has gone wrong with the nervous system, the injury is no longer there, but for some reason, the pain has persisted. So I'm not going to talk too much about the pathophysiology of pain, but just to build on what we've talked about with the concepts of pain, when there is an initial injury, there is normal pain, also known as nociceptive pain, which is from the activation of the nociceptors. The pain then transcends, it reaches the brain, and this is also overlaid by inflammatory pain from the release of inflammatory mediators, which is normal after a surgical procedure. In most cases, this would heal and patients would be fine without pain. In a percentage of cases, they will then develop neuropathic pain because of injury to the nerves, where the pain then persists. And what we actually talk about when we talk about acute versus chronic pain, because what the focus of this presentation very much is chronic pain. Now, by definition, this is pain that has persisted for longer than 3 months. In the context of orofacial pain, when we talk about whether pain is frequent or not, this is where pain is occurring for more than 15 days a month and lasting for more than 2 hours a day. And if it is chronic, it has to be present for at least 3 months. So, why does pain become chronic? And the reason for that is very much neuroplasticity. So, if there is repeated pain exposures, the pathways in our brain can change and it will make them more sensitive to future pain. And the threshold with which people feel pain or threshold with which the nerves can fire is actually lowered as well. So, the longer and the more often someone is in pain, it actually increases their risk of developing chronic pain because of these changes in the peripheral and the central nervous system that will predispose them to developing this. And we sort of call this peripheral and central sensitization. So it's a little bit like a highway. Like if cars drive over the highway all of the time, it needs to be reinforced. So pathways that are used more frequently become more reinforced. And the hallmarks of this central sensitization, so when there's a central component to the pain, includes decreased threshold firing, which is the process that I just talked about. So these nociceptors fire easily. There can be firing for non-noxious stimuli as well, because noxious stimuli activate the nociceptors and that causes pain. But there is this thing that's called allodynia with sensitization. The way that I like to describe allodynia, I have a patient that has trigeminal neuralgia and he comes in to see me, and he's a big Aussie dude and he has a big beard. And one day he came in to see me and he had shaved off half of his beard, and I was asking him why that happened. So it turned out that when he was trying to shave his beard in preparation for the dental appointment with myself, he could only shave half of it because shaving the affected side was causing him a lot of pain. So when you think about allodynia, that's a classic example where there is pain from a normally non-painful stimuli. There is something else that can happen with sensitization as well, and this is known as hyperalgesia. So hyperalgesia is increased pain to a normally only like mildly painful stimuli. So it's an exaggerated response. And these are the hallmarks of sensitization. Now, have a little bit of a think. How common do you think post-surgical pain actually is? Now, let's think about the medical literature. Let's think about maybe big surgeries like C-sections, amputations, cardiac bypass surgery. How common do you think it is that someone would develop chronic post-surgical pain? I'm going to take a guess that you are probably going to say something along the lines of it is fairly rare or it's not that common. Surprisingly, you may actually be surprised to know that rather, when we're talking about whether it's a horse or a zebra, it's actually more of a horse than a zebra. 10 to 50%. So acute postoperative pain is followed by chronic persistent pain in about 10 to 50% of individuals after common operations such as groin hernia repair, breast and thoracic surgery, amputation, and coronary artery bypass surgery. And among these 10 to 50% individuals that can develop chronic persistent pain, this pain can be severe in about 2 to 10% of these patients. This one here is a reference from this paper by Kellett, and you can see the estimated incidence of chronic pain for medical procedures, and it's very high for something like an amputation, 30 to 50%. It is about 10% post C-section. So neuropathic pain is actually not uncommon. Maybe in the dental sphere, it is not something that we think about or are aware of a lot. But the prevalence of neuropathic pain in the general community is actually more than 2%, which is quite a lot of people. About a third of cancer patients will have neuropathic pain, and that can be together with nociceptive pain. Having cancer and having undergone cancer treatment does increase the risk of non-protective pain, neuropathic pain. And this one here, we were just talking about it, Stephen, Geraldine, and I, because I currently do have some back pain from a herniated disc. But more than 50% of lower back pain patients have associated neuropathic pain. So neuropathic pain, not uncommon, pretty common after medical surgeries. Now, what about dental surgeries? It occurs less often than in a medical setting. However, I would hazard a guess that this number is probably higher than you expected. So the incidence following injury to the peripheral branches of the trigeminal nerve, following implants, third molar extractions, orthodontic surgery, midface fractures, and root canal therapy is about 3 to 5%. And this reference is from the International Association for the Study of Pain. Now, I've looked at the literature as well to see if there are other references as to how commonly estimated this is. And this paper by Renton has quoted that post-surgical trigeminal neuropathy is estimated to occur in about 4 to 5% of patients overall. Now, if you think about how often we perform these procedures, how often you might perform these procedures, and if you think about the reported incidence after dental treatment being about 3 to 5%, this is most likely something that you will encounter in your career at some stage, or at the very least know someone to whom it has happened to. Now, what are the procedures that are most likely to cause post-traumatic trigeminal neuropathic pain? TMS, which is the bars right there on the left-hand side, it stands for third molar surgery. So unsurprisingly, it is most likely to occur after bigger procedures such as wisdom tooth removal. However, if you have a look at the rest of this diagram, you will see that other causes are reported as well. And it may surprise you that it has been reported, for example, after local anesthetic, even for something as simple as a restoration under drill. So why is our patients developing chronic pain such an issue? I mean, the most obvious reason, and I think Stephen already alluded to this is very distressing for the clinician. I mean, I've had cases before, and I know many people who have, and these are sometimes the type of complaints or the type of issues that keep you up at night, right? Nobody likes to feel like they have caused an iatrogenic issue, or not be unsure about the diagnosis. Does the patient actually have trigeminal neuropathy, or is it a misdiagnosis, or is it a odontogenic issue? Wider than that, though, there are extensive costs to the individuals, government, and wider community. There's lost productivity, missed work, medical legal claims, and systemic health complications. So these issues are not pleasant for the community, not pleasant for the clinician, and not pleasant for the patient as well. And we may not think of this that often, but in the context of having, neuropathic pain in the head and neck region, it is actually fairly devastating because we do use our facial and oral muscles for a whole host of social activities, such as eating, drinking, speaking, kissing, applying makeup, shaving, and sleeping. This can cause significant psychological impact in over 70% of patients. And this number here surprised me, but now that I think about it, it makes sense. About 30% of patients who develop these issues report such a high level of disability resulting in unemployment. So let me tell you about this case here, which is Wallow versus Sadeghi. I think it's quite a famous case from the UK. So there was a dentist, Dr. Ali, who performed oral surgery to remove an impacted wisdom tooth from the patient Elaine Wallow. Now, prior to surgery, Elaine said that she signed a generic consent form for oral surgery, indicating that she was aware of the risk of temporary or permanent numbness or altered sensation of the lower lip, chin, gums, or tongue. And during the surgery, unfortunately, Elaine Wallow developed nerve pain. So she developed neuropathy, and this was devastating to her. And all parties agreed that this was bad. Now, Elaine was a flight attendant. She wasn't able to work anymore, and the nerve pain was so bad that basically she had drastically reduced quality of life, and it affected virtually every aspect of her life. And there was no argument from the dentist that the patient was suffering. Now, the patient actually sued the dentist for negligence, but by the time it got to trial, the parties actually agreed that Dr. Sadeghi had performed the wisdom tooth extraction to the standard of care that was required of him, and there wasn't actually too much wrong with the surgery itself. Where sort of the issue when what they were sort of discussing was whether the dentist had actually obtained consent from before the surgery from Elaine. So what the patient said was that she had signed a generic consent form, which said that she was aware of the risk of temporary or permanent numbness or altered sensation of the lip, chin, gums, or tongue. But what she said was that she was not expressly told that there was a risk of developing neuropathic pain. And when the dentist had told her about the possibility of nerve damage, he described it as pins and needles and tingling, and he didn't actually tell her that it could be permanent. So, Stephen, I might actually throw this over to you because I know you have a legal background, and I found this quite interesting because usually when I talk about these cases with the risk of developing neuropathic pain, what I suggest is that if anyone's doing sort of more extensive procedures such as wisdom tooth removal, that they do consider warning their patient about the possibility of developing pain based on my readings from what happened here with Elaine Wallow and Dr. Ali Sadeghi. What do you think about advising our listeners to consent their patients prior to surgery and making sure that they expressly also include that developing pain is a possibility, permanent pain or chronic pain?
Yeah, well, look, that's very interesting, Amanda. For those who don't know, my practice was an oral surgical practice, and so all day, every day, basically, I was taking wisdom teeth out. The interesting thing is that if I go back, to 1997 through to about 2012, I think it was, 2013, I didn't talk about pain. I talked about the normal things we talked about, numbness and tingling, and I actually wrote that, lingual and, the inferior alveolar nerve, and went through and explained that. But then in 2013, when I started my law degree and certainly finished there, I started to become aware of some cases that talked about pain. So it was somewhere in around about 2014-15 that every single patient I saw, we talked about permanent / temporary tingling, numbness, and pain. I had that written there. But more than that, of course, it wasn't just left at that. You need to actually describe what that means to people, because if you just rattle that off, they think, oh yeah, whatever. However, if it was a female, for example, I'd talk about how that would affect them. For example, putting lipstick on, something that's numb. Or if it is painful, it could be constantly painful, just to be aware of that, the seriousness of that. So absolutely, in this case, absolutely clarified that.
Thank you. I'm glad we're on the same page. All right, so now let's talk about who is actually at risk of developing chronic pain. The short answer is really anybody is at risk, because anybody who has a brain has the possibility of feeling pain. So no brain, no pain. However, there are, I think, certain risk factors that we can talk about. And when we talk about managing patients in pain, particularly in chronic pain, a lot of us describe it in terms of the biopsychosocial model of pain. And the reason why I like this is because it talks about the biology of the patient, psycho, and then social factors. There is a partial genetic susceptibility actually to developing chronic pain. And the reason for that is there are certain genes that can control the biological pain processes. So some patients are actually more predisposed to developing chronic pain, based on genetics. However, larger than that, and I think more significantly than that, are the psychosocial factors. So when I was working in the public system as a registrar, I noticed that a lot of my orofacial pain patients did not get better. So they may have some improvement in their symptoms, but not 100% and not curative. I then, started to work in private practice, and I managed patients with similar diagnoses. And the management is the same with me; it's the same clinician, same sort of thing that I'm doing. But my private patients seem to get better more frequently. And then I realized that the reason for that is that the patients that I was seeing through the public system had a lot more significant psychosocial factors. So it will be things like financial issues, for example, a work cover claim. Work claim is an interesting one. So when I talk about work claim, the literature is clear that patients who have, say, an ongoing work claim actually have a poorer prognosis. But that doesn't mean that they're doing it on purpose. So they're not malingering. They're not like pretending to be in worse pain than they are to try and get more money out of work cover. It is just a really interesting psychological process where they do have a secondary benefit from remaining in pain, whether they can control that or not. It'll be other things like access to care as well, family support, sleep, alcohol, and other pain. And with the psychological factors, I'll talk about some of the personality traits that can predispose a person to developing chronic pain. And they would be things like catastrophizing, like always going to the worst case scenario, somatization, which is where people can manifest their emotional distress physically. So, for example, if I say that whenever I'm, really anxious, I start to get really bad stomach pain, that'll be an example of somatization. So, it is this complex interplay of the biology and the psycho and social factors that can actually lead to the initiation, perpetuation of chronic pain. Another thing that I do like to sort of mention, because I like to talk to my patients who have chronic pain in terms of risk and protective factors. So the more protective factors that someone has, I think that can balance out the risk factors that they have. So when I talk about protective factors, it'll be things like, a good level of physical activity, a good level of sleep, supportive partner, and then the more risk factors someone has, I think the more we have to modify what sort of protective factors that they have. So the more that they will have to do physical activity, get out of the house, even some simple things like, having a pet. Not that I recommend that everyone goes out to buy a pet, but if they do have a pet already that they're fairly attached to, spending more time with the pet, taking the pet out for a walk, things like this can all shift the balance towards a more protective factor for developing chronic pain. So in a genotypically or phenotypically vulnerable patient, complex biopsychosocial factors may lead to the predisposition, initiation, or perpetuation of orofacial pain disorders. And this one here is a great diagram that I really like. So we have axis 1, which is where there's somatosensory input. So this is your nociceptive pain. This is the example that I gave you of someone burning their hand on a stove and pulling it away. So this is acute pain, and usually it heals with time. However, as you notice in this diagram, as time progresses, as there is more axis 2, so as there is more psychosocial input, it is more likely then that the patient will start to develop chronic pain. So as time progresses and there is more psychosocial input, the pain perpetuates, and this also directly affects the patient's suffering and pain behavior. Now, it would be really good if we had a crystal ball and we could predict which patients these were. Unfortunately, we don't have a crystal ball, but I do have a few tips for you. So is it possible to predict the transition? So I'll give you 2 examples here, and I know this is oversimplified, but this is just to illustrate, I think, a point. So we have 2 patients, patient A and patient B. Both are female, 35 years old, and both of them are now experiencing severe chronic pain after severe pain after a simple wisdom tooth extraction. This is acute pain that we're talking about, right? The wisdom tooth has been taken out, let's just say 3 days ago, they're in a lot of pain. Medical history for patient A, hypothyroidism, depression and anxiety and migraines. Patient B, hypothyroidism. Patient A has a lot of social issues. She is divorcing her husband of 3 years. She's trying to get a restraining order because of domestic violence. There's a difficult custody battle. She's not sleeping very well. Patient B has a stressful job. She has a dog. She feels like she's doing quite well. Now, if you had to predict, again, I'm aware that this is an oversimplification, but if you had to pick a patient between the 2, patient A and patient B, who do you think will be more likely to develop chronic orofacial pain or post-traumatic trigeminal neuropathy? And I'm hoping most of you would say patient A because that would be the patient that I would pick as well. So some of the risk factors of developing chronic post-surgical pain is if a patient has been in pain for quite a while, so more than a month, and moderate to severe pain prior to seeing you. So these are the pre-operative factors. If they've had repeat surgery, if they're psychologically vulnerable, if they're very anxious about the procedure, if they're female and they're young, if they're going through a workers' compensation case, and then, the other one about a genetic predisposition, you can't really tell that. Now, intraoperative factors, there are ways and there are more learned people than I am who can give advice on this, but basically atraumatic techniques wherever possible. And then post-operative factors, and Geraldine will be talking a little bit about this later on, how to actually make sure that we've got good analgesia for patients perioperatively, and postoperatively. Now, other risk factors for developing chronic trigeminal neuropathic pain would be other comorbid pain conditions, which I will show you some examples. They have some listed here, which are chronic headaches, chronic neck or back pain, irritable bowel syndrome, and fibromyalgia. However, there are a host of these conditions which we call central sensitization syndromes. And if a patient has more than one or two of these, you know that they are basically a chronic pain patient, not just chronic orofacial pain, but they are basically in chronic bodily pain. And these are the patients that need more TLC. These are the patients that you don't rush the appointment through. If the patient is telling you that they're in pain during the procedure, you need to stop and make sure that their level of analgesia is adequate. So independent predictors of severe postoperative pain in the acute setting is younger age female, the level of preoperative pain, and the type of surgery. So atraumatic techniques wherever possible. Other things include smoking. So smokers unsurprisingly have a higher risk of developing chronic pain. History of depression and anxiety, pain catastrophizing, sleeping issues, higher BMI, and not having good analgesia. Now, this paper I really like. So they looked at 708 patients undergoing root canal treatments and they followed them up. What they found from this paper was that every single day over the week preceding treatment, every single day that a patient remained in pain after that first week, there was a 19% increase in risk of them developing severe or persistent pain. So I suggest that if you do have patients that are calling you and that they're telling you that they're in pain, or if you're doing a post-op call to the patient and they tell you that they are in pain, that you manage their pain levels as quickly as possible, because you don't want them to stay in pain. The longer they're in pain, remember we talked about the highway and the cars going across, and the more reinforced these signals are, it is important to bring these patients in sooner. The other bit that I really like about this paper that I highlighted in yellow, it was that optimism about the procedure actually reduced the risk of them developing severe and persistent pain. So if the patient feels confident in what you're doing, and this goes towards talking about building rapport with the patient, making sure they understand the procedure, making sure they're comfortable. If they like you and if they are optimistic about the procedure and they feel like everything has gone well, actually they tend to do better. Now, with the example of the pain conditions there, the diagram on the right-hand side gives you more examples. So chronic fatigue syndrome, fibromyalgia, vulvodynia, endometriosis, TMD, back pain, tension-type headaches, interstitial cystitis. It is good to become familiar with these diagnoses so you can recognize when someone has multiple of these conditions, and then this should flag to you that you need to spend a little bit more time with these patients, or at the very least, you want to make sure that you are taking care of them so they don't remain in pain too long after the procedure. They are less anxious about the procedure and they know what's happening. The other predictors that we haven't talked about yet, neuroticism. So that is one of the personality traits that can predispose to someone developing pain. The other things like stress, anxiety, and catastrophizing we have already mentioned. Now, if this piques any interest for you, we did record a webinar some years ago now for the International Association for the Study of Pain. This is a free video that is available on YouTube. It is a little bit longer. However, I co-presented this with two individuals who are very learned in the field, so it could be one that is worth watching. All right, now what are some things that you don't want to miss with chronic pain? First thing is incorrect diagnosis and management, and that is a big one. So don't be misled when a patient comes in to see you and they tell you that they have a toothache, because a toothache is merely a term that the patient uses to describe that they are having pain in the facial region. It's not actually a diagnosis. They're not telling you their diagnosis. So if they come in and see you and they tell you that you have a toothache and you think this means that their pain is definitely coming from their tooth, that's not the case. Now, the accurate terminology for an actual toothache is dental alveolar pain. Dental alveolar pain is easily, or not easily, dental alveolar pain is treated by what dentists do, which is well-established dental procedures. Now, I'll go through a couple of interesting published cases. I know that there's a lot of words on the screen, so don't worry about it. I'll talk you through it. So, case one here is of a middle-aged person, a lady, who reached up to grab a small plastic box of facial wipes from the closet shelf. Now, unfortunately, this small box of wipes actually fell and landed on her face and it struck her upper lip. She started to develop pain in tooth 2-1. She went to see her dentist, dentist number 1. The dentist number 1 couldn't find anything wrong with the teeth and advised her to wait and see what happens. Over the next 6 months, unfortunately, she was still experiencing pain. So dentist number 1 referred her to dentist number 2, who was an endodontist. Now, endodontist 2 didn't actually find anything wrong with tooth 2-1, but eventually he was persuaded to perform a root canal treatment. Now, he said that when he did the root canal treatment, there was a vital pulp that might have been slightly hyperemic. Unfortunately, her pain got worse, and the endodontist then suggested that the patient wait and see what happens, and he took a coin beam CT of the area and didn't find anything wrong with the area. Now, at this stage, the patient became very frustrated with dentist 1 and dentist 2, which was the endodontist, and she decided to get a second opinion. So she found a prosthodontist who was dentist number 3. And what the prosthodontist did was that he examined her about 2 months after the root canal treatment was done and referred her to a periodontist, dentist number 4. Now, dentist number 4 didn't really find anything wrong with the tooth, but he thought maybe it was cracked. So he extracted the tooth and placed an implant. And then a temporary crown was placed by the prosthodontist, which is dentist number 3. The pain persisted. Patient then saw another endodontist, and then the pain was getting worse. The same cycle actually repeated. So they decided that maybe tooth 2-2 was the issue. So they decided that tooth 2-2 should be extracted, and then so tooth 2-2 should be root canal treated. Sorry. The pain was getting worse, and they decided that maybe it was an implant issue. So then they removed tooth 2-1 implant. The patient was then referred to see another periodontist and then another endodontist, and they completed root canal treatment on the 2-2, and then they decided to extract 2-2 because they thought that maybe the root was cracked again. So the patient has an implant on 2-2, which still stays. Now, this happened over a 3-year period, and the patient's pain gradually worsened. She went to see a neurologist who thought maybe it was trigeminal neuralgia. Then she saw a second neurologist, and then she saw an oral surgeon who thought that there was this condition called NICO, which is neuralgia-inducing cavitational osteonecrosis, which is not a real diagnosis. And then they decided to do, they then recommended a surgical procedure to operate in the area to remove bone. Patient got very distressed and was eventually ended up referred to an orofacial pain specialist, and she was diagnosed with a neuropathic pain condition. This patient was very understandably distressed and decided to sue all 7 dentists that she saw. And the 2 dentists that got away with being sued was dentist number 1, who didn't actually do anything wrong, and the first endodontist, who they decided that the procedure was acceptable. So a malpractice suit at the time of publication of this paper was brought against the 5 dentists, and the outcome of the action was still pending. Now, it is easy to see in hindsight when I describe this published case where things went wrong. However, if all we have is a hammer, everything is going to look like a nail. We need to consider that if patients are not getting better, if the pain is atypical, if there's anything unusual, that there would be a diagnosis worth considering beyond that of an odontogenic source. So I think it's really important. And I've seen that happen a few times as well in very good dentists, where they end up, they get tunnel vision. They think that something is related to the tooth, and they sort of go down a little bit of a slippery slope. It is always worth taking a pause when something has not healed or when something is not going right to reassess. Now, I'll illustrate this point again with another case. This is case number 2 that was published, and the reference is there. Now, this one here was a 27-year-old woman. Now, the difference between the first case and this second case was that this person, this lady, was actually diagnosed correctly. However, she did not want to accept her diagnosis, and she wanted to find basically a magic cure. She wanted to find someone who could correct what she perceived as her occlusal problem and make her pain disappear. And she was diagnosed with neuropathic pain, but she did not accept it. So initially her problem started as pain in the maxillary right arch in the premolar area about 5 years earlier. She saw her dentist, who thought it was due to pulpal inflammation of the first premolar, and then a root canal treatment was performed. Now, what happened after this initial improvement was that the pain went away before coming back. And this can happen when we are treating things like neuropathic pain. The placebo effect can be quite strong, and patients can sometimes see an improvement after any sort of intervention. We do have to be careful that this doesn't mislead us into thinking that we've got the diagnosis right, because the pain has gone away, because if it comes back again, then you know that that hasn't happened. So the pain went away, but then it came back, and then the dentist then thought, okay, maybe it is the neighboring teeth that are the issue. So then he did root canal treatments to try and get her relief from pain. And this pain was migrating from one tooth or another to another. Now take a guess how many root canal treatments were actually performed. 28 for persistent idiopathic dento-alveolar pain that had nothing to do with an odontogenic or pulpal source. So the dentist did 28 root canal treatments and crowned them all. And these are the photos. So what are some of the points here that stood out to me when I was reading this paper? So her overall pain increased after all of these interventions. There were alternating periods of some remissions and some worsening episodes, but don't let this be a red herring. This patient described the pain as an electrical stimulus. There was a burning sensation in the gingiva. There was a bad taste. She was having frequent headaches. All of this is unusual. So we need to also not have our blinkers on when it comes to other sort of neuropathic signs. Now, when she didn't improve, the dentist then suggested an escalation to a third step treatment. So don't forget, this is a dentist that has done root canal treatments for 2018. He did crowns on them, and then when it didn't work, he was like, okay, let's do full mouth extractions, and then let's do a implant supported prosthesis. At this point, it should have been much earlier, honestly, but at this point, the patient got cold feet and decided to seek a second opinion. Again, we do have to be careful that we are not getting misled into doing treatment for non-odontogenic causes of pain. So we do have a responsibility to avoid excessive and repeated dental treatment when it is an incorrect diagnosis. And there are two types of failures, which is failures of omissions and failures of commission. The failure of omission was the failure to be aware of alternate diagnoses, to stop dental treatment when the patient wasn't getting any better, to refer the patient appropriately to someone else who could give another opinion, and to listen carefully when the patient was reporting negative outcomes with escalating pain. And the failure of commission here was basically escalating to more aggressive procedures, relying on crude examination techniques, and allowing the patient to dictate treatment.
Okay, Amanda, we might have a break now after those two cases have sent shockwaves through us all. So we're about to take a short 1 minute break, but don't go anywhere. We'll be right back.
You know the feeling. You sit down with a new patient, ready for their initial exam, and they hand you a medical history that reads like a novel. Pages of unfamiliar syndromes and medications you can't even pronounce. You look in their mouth. How do you treat those severely worn down teeth? And what about that asymptomatic tooth that appears to have an apical radiolucency? What's the next step? The Dental Advice Network provide timely, practical and expert advice to all members of the dental care team. Dan's online helpline is your direct access to trusted, clear advice from the people who know their fields best. In addition, Dan offers online resources, webinars, and even step-by-step instructions for writing scripts commonly required in dentistry. Why struggle alone? Let Dan help you simplify complex cases, minimise risk, and provide safer, more effective patient care. Subscribe today at dentaladvicenetwork.com.au.
Okay, well, welcome back, everyone. Just before we go back to Amanda, she talked earlier on about informed consent and valid consent. Just to clarify things, Generally, in the health game and with doctors and dentists, we talk about informed consent. Have we fully informed them? But if something moves, beyond that into the court system or some type of a legal issue, you'll often hear the word valid consent. And the courts look at it in terms of, was the consent valid? You may have informed a patient of all the risks, but was it actually valid? In other words, for example, were you giving all this information to a 9-year-old? No, that's not valid consent. Even though you've informed them fully, they're obviously a minor, or they may not have the mental capacity to fully understand what you're talking about, in which case the court may find that even though there was informed consent, not valid informed consent. And same with someone who maybe has English as a second language and may not have understood things. So I just think that's interesting, just to clarify those terms. But Amanda, after those two horrifying cases, we look forward to hearing a bit more from you now. Thank you.
Thank you. So, what are some of the red flag signs that should send, a little bit of a question mark into your mind when you're seeing patients with, facial pain? Any sort of neuropathic sort of sign where they sort of say, there's any sort of tingling, burning, shooting, numbness, I think that would be more unusual signs. If the patient has pain that wakes them up in the middle of the night, that is actually most likely to be an odontogenic source. Things like trigeminal neuralgia and neuropathic pain and temporomandibular joint disorders don't tend to wake patients up at night when they are already asleep. If they have constant background pain that is sort of superimposed with short attacks, that's also a little bit unusual. And then any sort of, unusual sensation where they feel like their saliva is thick, or where they feel like something is swollen, or something is very painful, something's a little bit red, a little bit numb, all of these would be unusual. With the swelling as well, it is not unusual for patients to describe actually a mouth swelling, but when you have a look, it doesn't look swollen. So they can feel that happening, and that can be one of the neuropathic symptoms, which may not be clinically apparent. All right, a few more practical clinical tips. So, pre, peri, and post-op interventions. Now, this is quite interesting when looking at the medical literature, because I think pre-op interventions by giving patients medications before surgery is more commonly done in the medical setting, not quite done as commonly in dental. So they have tried different things like, tramadol, bupivacaine, ketamine, etc., etc. That is definitely not what I'm suggesting that we do. This is just sort of give you a little bit of background, and I'm hoping that this could be something that would emerge a little bit more in the dental surgery space. What I think is important that we do is that we do consider good peri and post-op analgesia, so we make sure that patients are comfortable during and after the procedure. And we do want to make sure that we are giving good local anesthetic to patients so they are comfortable during the procedure. So none of that, patient doing a root canal treatment and they start to say something is painful and you tell them to tough through it. Not that I think that many of us would do that, but, especially in patients that have these risk factors of developing chronic pain, it is important that we stop and readdress, because one of the risk factors, for example, for developing chronic pain after local anesthesia is severe pain on injection. So these are not patients that we decide to push through. These are the ones that we stop, give the patient a break, and then we redo the local anesthesia. All right, now over to you, Geraldine.
Thanks very much, Amanda. And, I see what you've presented is fantastic and covers such a wide area of influences on the development of post-procedural chronic pain. But what I want to emphasize is the medicines. As a clinical pharmacist, I sometimes sit here going, where are the drugs? Because people don't talk about them enough. And in all those cases, they really weren't explained what medicines people were on. And in the Australian community, we've noticed since the upscheduling of codeine that you may remember, some of you, that it used to be available over the counter. You could just romp into a pharmacy and buy Panadeine up to 15 milligrams per tablet over the counter, no problem, get as many as you like. A lot of the patients who purchased that were chronic pain patients. They were very cranky when they changed the availability to being prescription only. But what's been identified since that upscheduling, and similar upscheduling has occurred in other countries around the world, is that people have much less codeine-related chronic pain. So it's been sort of elucidated with that opioids contribute to the development of chronic pain. So we've got to ask people in that acute phase what they're doing to manage that acute pain. And certainly your role as dentists is to make sure people's post-operative, post-procedural pain, and as well, as Amanda said, hopefully pre-procedurally as well, for preemptive pain management. But in the post-procedural period, make sure there's adequate analgesia. And typically what we're finding is an over-reliance on opioids. Now, Amanda's already explained that, acute pain is easily identified. We know where it's coming from. Most of it's nociceptive. It's short-lived, well-characterized, and usually we can sort it out. It even goes away by itself. But with chronic pain, it's a different animal altogether. And that's what we've got to explain to patients, is that it's not like acute pain anymore and should be managed quite differently. And so I like to also mention acute on chronic, because a lot of our patients, as Amanda suggested, we're patients with other conditions, even things like autoimmune disease, like rheumatoid arthritis. And then when they get dental pain, we've got to manage that pain, which can be inflammatory pain on top of their chronic inflammatory autoimmune disease. So that becomes very challenging. But the point is, we have to stop people from managing chronic pain 3 months down the track when it is becoming persistent pain, as if it were acute pain. I really feel this is one of the biggest mistakes that clinicians make, is that we're not making that clear to patients, that we shouldn't be continuing the search for the magic drug that will make the pain go away, and rather that when people have developed their chronic pain situation, and we know the types of people that are more likely to develop it, and even, the personality types that contribute, such as catastrophizers, who, it's important that we don't judge these people as just having a negative attitude. They also often just lacking health literacy, because one of the interesting things in catastrophization is that they think that all pain is dangerous. Now, you and I wouldn't think that pain is dangerous, but catastrophizers often do. And so a lot of that can be resolved by education, not by giving them more drugs. So you can see here that the acute pain algorithm is you start with the simple analgesics, things like NSAIDs and paracetamol. You could work up to the less potent opioids and stronger opioids in this acute phase for the first sort of days to weeks. But as time goes on, we need to move away from drug management, and particularly away from reliance on opioids. Also, we need to be avoiding anxiolytics, because as you've seen, the mechanism by which hyperalgesia and allodynia start to become embedded in the patient's central sensitization is due to excitation of their central nervous system, particularly stimulation of NMDA receptors. So this is some of the mechanisms. I could have had a pretty picture, but we don't have time. But these things are activated by the patient's hypervigilance and their anxiety, and that also generates pain. But it's been shown that the opioids and the anxiolytics, like things like benzodiazepines, contribute as well, and so we have to move away from those drugs. So looking backward, we'd always say make sure you hit that acute pain early and hard. Use NSAIDs and paracetamol, trying not to use opioids, because people will think that's what they'll keep using and then increase the dose if it continues. Also, I wanted to say to maximise the efficacy by taking them away from food, and to consider COX-2 antagonists like celecoxib and meloxicam in patients who claim NSAID intolerance. I recently wrote an article for Australian Prescriber. Was published last month in August about the role of COX-2 antagonists in managing inflammatory pain in dentistry. So if you're wondering how to prescribe drugs like celecoxib to dental patients, there's a whole article on that. You can go and have a look at full text. And so I think that's my last slide. That's pretty much all I wanted to say about making sure you look at the drugs and try and educate people away from using medicines as the pain becomes more chronic.
Thank you, Geraldine. So I think I will start to wrap up my slides to leave time for questions. But I did want to highlight this paper. It is a little bit of an older paper now, but the point still stands. So this was a paper by Renton et al. In 2012, where they looked at 30 patients who developed post-traumatic trigeminal neuropathic pain. 8 of them felt that they were not explicitly warned about the possibility of nerve injury, which is why we discussed, we highlighted the Wallow versus Sadeghi case. Over 70% of these patients were referred after 6 months post-injury. So I do understand sometimes that it can be difficult. I think there is a lot of self-blame. So dentists do have to take care of themselves as well, because I know these cases can be difficult. But there's no point burying your head in the sand. If you do suspect that the patient has developed post-traumatic trigeminal neuropathic pain, or if something's not quite right, these are cases that are worth talking to your indemnity insurance, for example, just having a chat with them, or referring the patient appropriately to your local specialist. And where the blue star is, it shows you that out of these 30 patients that they looked at, 10 of them were referred over 12 months after the initial injury, which is a long time for this. So how we usually manage these cases, these are usually at specialist level in a multidisciplinary setting. We can manage them via, sometimes with pharmacologic means, and also equally as important, I think, is psychological support for these patients, because as we've discussed, their quality of life can be significantly affected. And I do, for example, work with psychs as part of our management plan. All right. So we've already talked about how iatrogenic, we should go with atraumatic means. Some of the ways that can cause injury that we may not necessarily think of would be, for example, inflammation or infection itself can actually be causing nerve damage. So this can be relevant, for example, in a tooth that you're going to root canal treat. There can be leakage of the chemicals. There can be over-instrumentation and then mechanical damage. There can be mechanical compressions due to overfill or extrusion. A hemorrhage itself can actually cause nerve damage as well. With surgery, as I said, I'm not the best person to talk about surgical techniques, but it would be things like avoiding lingual retraction and trying to be as gentle as possible. And then there are other means, such as if you do suspect that the patient does have risk factors, like they had severe pain on giving, for example, an inferior alveolar nerve block, you can change the style of block that you're giving and give something like a Gaugate's block instead, which is further away from the nerve. I might skip the informed consent because we've already talked about that. So maybe what I think, Stephen, would be best, let's take some questions and see if there are anybody that have things that they want us to clarify.
Great. Well, thanks, Amanda. Yes, we have got a few questions here, and a couple of them are interesting. I'd like to get both your perspectives on a couple of these. One of them here is, should I pay for my patient to see the specialist if they have developed post-procedural pain after something I did? That's an interesting question. So what are your thoughts there, Amanda?
So I actually see this frequently, because I do get patients that are sent in for an opinion, or if they've got pain and the patient feels like it's caused by the dental treatment. My advice is to always talk to your indemnity insurance and follow their advice. In multiple cases, indemnity insurance would advise that maybe they would pay to get an opinion, and in some cases, they will. The dentist has actually done nothing wrong, so there's no reason why they should be paying for the consult. I do not suggest that dentists offer to pay for these consultations off their own back, because a lot of times I think patients would treat it as a admission that the dentist has done something wrong. So that could actually be making things worse. So I would advise that if you're in this sort of situation, speak to your indemnity insurance. Don't offer to pay for the appointment unless you have heard that that's what indemnity insurance has offered you, has suggested you do. Because the last thing you want it to do is for it to be misconstrued as a admission of guilt or liability.
Yeah, I think that's really good advice, Amanda. In any of these type of situations, contact your insurer straight away and run through there. Or if you're a member of some organisation, some of the state branches may have peer advisors, get in touch with them straight away. Now, this next question will be one I'll get a response from both of you. How can I tell if the patient is genuinely in pain versus someone who is drug seeking. So, Amanda, I'll get you to talk first, and then Geraldine. Obviously, I think this is something that you'll have a bit of information about as well.
So I'm actually really interested to hear what Geraldine would say. So I do know that there are ways in WA. I'm not sure if it's as established as over east, to be honest. But there are, there's a government website that you can use to check if the patient has accessed more of these types of scripts than they should have. But typically, I think if the patient is exhibiting drug-seeking behavior, I feel, then this is sort of like a gut feel, they come in very focused on the medications. They know what they want, and they are fairly cagey in their responses. So I think sometimes you do get a gut feel based on the patient's demeanor. But I will throw it over to Geraldine because I'm sure there are resources that you can point us to.
Yes, absolutely. Thanks, Amanda. Actually, thank you for mentioning it because it is actually something that all people in the dental profession should know about. It's called WA Script Check in WA, Safe Script in New South Wales, ACT, and somewhere else. So it's got a different name in every state. Q Script in Queensland. I think it's still called Safe Script in Tassie. Anyway, it's real-time prescription monitoring. And so rather than relying on a feeling in your waters that the patient is drug-seeking, this now interstate system has been developed by the federal government that we can check in real time to look up the patient's name and date of birth, and you can see what they've had dispensed. Now, it doesn't say what's been prescribed. It's not looking at prescriptions that people have written. It looks at what has gone to a pharmacy and been dispensed because it's collecting the data from pharmacies. And so you can actually then see, in fact, what they've been accessing rather than just going, I think they could be looking for drugs. And it's been tremendously helpful for clinicians. I see this in the hospital all the time where I work, community pharmacists. It's mandatory in Queensland now, so several dentists have told me they just think it's fantastic that when they get a request from the patient saying, can I have a box of Valium, please? They can go, oh, come back in 2 minutes. They quickly go and check Q Script. And a couple of people have told me they looked it up and the whole thing just lit up like a Christmas tree with warning, warning, warning that this patient who looked so innocent was doing the most magnificent Academy Award performance, was accessing benzodiazepines from multiple prescribers and multiple dentists in the local community, but you just wouldn't know otherwise. So that's what I'd suggest, that you could be thinking about it from a feeling in your waters. Certainly, as Amanda said, the fact that they might be very focused and have their script set out to access the drug they want, but go and check your safe script in your state. And it actually is mandatory in a lot of states and already is in WA and will be soon in the ACT and New South Wales.
Yeah, great. Thanks, Geraldine and Amanda, for that. I've actually had this situation occur myself. It's only happened once, but I had a young lady come in for a consultation. She was, I think, about mid-20s, and she was complaining of this pain. And I had a good look around and looked at the x-rays and could not see anything that matched what she was telling me. And she then told me, and so I said, well, we can wait and see what this, how this goes, or we could, if it's that bad, we can actually give some non-steroidal analgesics. But straight away, she knew exactly what she wanted. She wanted endone, 5 milligrams, and the way she said it, and the way it didn't correlate the pain with what I saw there. For the first time, I actually went on SafeScript and just said, I'll just be a moment. And I had my computer so she couldn't see it and typed in her name. And I couldn't believe what I saw. It just, a whole page of warnings came up. And she had multiple scripts for opioids, benzodiazepines, lots of paracetamol with codeine, Pantene Fort. And basically then the penny dropped, and I let her know that, look, because it's the first time she's seen me, we're only going to give paracetamol and prescribe paracetamol. That's when she knew it was up, and she just basically stormed out of the consultation. No, she didn't pay for the consultation, but I thought, just go. And but it was very obvious. So that's one time. So I'm glad that this real-time monitoring prescription monitoring system is coming into place right around Australia, and eventually it will be compulsory everywhere if someone's about to prescribe a monitored drug. I think that's the correct term, monitored drugs.
That's right, monitored medicine.
Monitored medicine, and I think it's very worthwhile. So anyway, I know the benefit of that. I think we've got time for one last question here. And this one is, will the patient signing a consent form absolve me of any issues if they do develop procedural pain? Well, I kind of might know the answer, but Amanda, what do you think on that?
No, it won't. So my understanding is that the piece of paper is not really that helpful at all. I think you would have to demonstrate that you have spoken to your patient about it and that they actually understood what you were talking. But, Stephen, with your background, maybe let's hear what you think.
Oh, well, I think that's a fairly obvious one to me. No, it won't cover you. As we've heard 1,000 times, it's not a bit of paper. It's the whole the vibe, if you almost want, of everything. Does the patient really understand what I'm saying? And so it would not be uncommon for me, if I had any doubt that they were understanding what I was talking about, to just ask them a little question. So what did you understand from me talking about the nerves? And I'd get them to say that back to me. So we all know what's required. But the biggest tip I can give to anyone, really, after nearly 40 years of dentistry, is just be frank and open and honest and write everything down. It's just so straightforward and easy to do. And if you do that, you can get through a whole career without any major dramas, particularly, that old story of patients don't want to sue a friend is true. Be able to talk to people, communication skills, all of that kind of stuff. But the answer to that question is just sign a consent form. No, but it is one bit of evidence. It's a help, but certainly you've got to go right through and make sure they actually are understanding what you're saying, particularly if you're doing something complicated. Okay, I think that's all we've got there today. That's the last question I've got there. So I would like to say that's all we've got time for. Don't forget that if we didn't get to your question, I think we've got through most of them, but there's still a few there. DAN members can have direct access to all of us via the DAN website. So the other thing I want to say, by the way, I just remembered this, on the DAN website, particularly if you're not used to prescribing certain drugs, Geraldine has actually put up prescription examples for nearly every drug that we prescribe in dentistry. If you want to know exactly how they should be written and some information about them, have a look at that. Now, this evening, we're offering a discount code exclusively for those who tuned in tonight. And you can find the link for that at the bottom of this page. So don't miss your chance to get DAN membership at that discounted price. Now, from all of us here, I thank you all for tuning in, and we look forward to seeing you for the next episode of DAN Live. Geraldine, thank you, and Amanda, thank you so much, and I hope everyone enjoyed tonight. Thank you.
Thanks, Steve.